Before I go any further, I'd like to introduce Dr. Fernanda Arnaldez. Did I get it right? And obviously she's going to give us an update on where the current American, well, we're only 2 clinics in the whole of the world, so it's pretty amazing really, and we need to know what's happening and where we go from here. So thank you very much.
When you speak right after your mentor, chances are 35% of the slides are going to be almost the same. And that's what you're going to have to endure. However, I am going to try to give it a different spin and focus a little bit in the operational aspects of the clinic to leave our colleagues here to expand a little bit more on the scientific aspects of it. And please feel free to interact with questions, or we can leave them for the end.
Did you take the one on the podium seemed to work?
Oh,
I kept
I
changing.
don't like the podium. Okie doke. To the podium it is.
Is there a different controller on the
Okay, so I work for the government, so no money. So my interest was to give an overview of the clinic, to give an idea of what are our findings and our contributions, the highlights, and our future considerations. You saw this slide, right? So you all, unfortunately, know what GIST is about. It's a common mesenchymal, meaning interstitial tissue type neoplasm in the GI tract. We think now, and there is some evidence, that the cell of origin is the interstitial cell of Cajal, and those cells, what they really do, if you think about a tube as your GI tract, is to be the pacemakers and to allow that GI tract to move food forward as opposed to having no motility at all. As Lee very well said, it was introduced as a diagnostic term in 1983, and this has an implication because when you look for literature from before, it's very hard to identify what is what. So when you want to do a retrospective study and you say, wait a minute, this is not new, we can look what happened in the past, it's not that easy. And the KIT mutations that many of you are extremely familiar with were described in 1998. So I'm not going to go through the presentation and the location because we just reviewed them. And many of you have had endoscopies after bleeding, after pain, after different symptoms. And this is how it looks from the outside, are really tumors that erode through, most commonly, the stomach, and they push, and occasionally that surface can ulcerate and give origin to bleeding. And that's one of the key symptoms that many of you have experienced. This is how it looks under the microscope, and we are fortunate to have as part of our clinic Dr. Marco Mietinen, who is in the audience. He is shy, so he won't make many comments. And Marco, could you please raise your hand? Dr. Marco Mietinen is a world expert pathologist, and he has helped us define many of the pathological features of GIST and other sarcomas that and we are delighted to learn from him every week when we meet. So, back to planet Earth, 85% of GIST have mutations in KIT, 10% have mutations in other tumors, that in other genes that is called PDGFR8. And for these tumors, there are different strategies that our colleagues in medical oncology know very well. You can do surgery, and you can use different tyrosine kinase inhibitors that work well. Dr. Herman just described how when imatinib came up to the scene to treat chronic myelogenous leukemia, and it was what in pharma people would say a slam dunk, it was really fortunate that it had a profound effect in GIST. So that was implemented very quickly. However, there is another 5 to 10% that is like, they don't have any of this. So what are those? What are these tumors? Why do they not fit the mold? And as Lee described, there were young patients, mostly young patients, scattered around the country. And if you think about a rare disease where a physician could see one patient per year, maybe, it's very difficult to learn. It's very hard to learn from the anecdote. And that is why it's so important to have initiatives like the one that is set up in NIH, the one that Ramesh has set up in the UK, because that's the way to learn, to group all of us together. So, once upon a time, There were a group of visionary leaders, and they talked to Norm, and I am depicting two pictures. Disclosure, this is not an old picture, this is a little bit newer, so you can see what the time has done with Dr. Lee Hellman's face and Dr. Alberto Papa's face. But these are true giants of oncology who were able to put their vision into action. Many people have great ideas and go to sleep with great ideas and do nothing with them. But these ideas were spearheaded into action, and the action had results. So I think that that is a critical thing that I wanted to highlight. And the clinic started, and you can see, and I'll go back to that, there is a significant amount of different clinicians, genetic counselors, pathologists, medical oncologists, pediatric surgeons, that all got together in a very selfless way, because all these people that traveled to DC really donated their time to try to figure out what was happening and how to make an impact in the GIST community. You saw this slide, huh? So many different institutions working together to try to learn and make an impact. And oh man, this picture doesn't show well. I really wanted to show you. So here in this angle is Dr. Soo-Young Kim. Dr. Kim was a junior investigator in the pediatric oncology branch under the leadership of Dr. Lee Hellman, and he really took upon the effort of having the first clinics set up and organized, and to make sure that things were working in the way they were supposed to, except that we didn't know how it was supposed to work. So I think that he deserves a very big credit. Many of you have met him. He's a wonderful physician. And I would like to make sure that his name is up on the screen because it's very well deserved. Now, focusing on how the clinic works. I already said it's multidisciplinary, and that's key. Beyond the oncologists and the surgeons, we have the luxury of having incorporated in our team geneticists, endocrinologists, genetic counseling, which is critical in these conditions, state-of-the-art pathology, radiology, psychology, behavioral therapy, our nurses, nurse practitioners, nutritionists, dermatologists, pain specialists, care coordinators. Our head of operations, who is my right and left hand, works tirelessly, and many of you have spoken to Claudia a million times already, to make sure that all this is flowing not once a year, but year-round. And that's a very significant effort, because that is not her only task. There is no personnel in all of that you are seeing that is solely dedicated to the GIST clinic. And this is not minor, because it's a lot of effort. It's multi-institutional, and I listed some of the institutions there, and it's fluid. It's fluid the way we continue to associate with different colleagues. And it embraced a truly collaborative model, and I would say a selfless model. And in that sense, we got lucky, because the group of individuals that started working on this is a very particular group that is really driven by the passion of making an impact and trying to improve outcomes. And we got lucky in the sense that we all it became clear immediately that we shared the same goal. And the other critical aspect of it is that the advocacy community, and I don't need to tell you who you are, immediately embraced the concept of this clinic, immediately supported, immediately spread the word. They believed in trying to make a difference. And I think that that is critical. If you think about a rare disease in an obscure clinic in the NIH, suddenly having such a reach. And I think the advocacy community there is key, critical, because to use a cliche, we did not stay in a sort of an ivory tower. We were really working with the people who needed it, and that was critical for the development of the clinic. So what did we find? And some of these things we went already over those, and we'll see them in more detail later, so I'm going to just gloss over some of them. So the vast majority of what we call wild-type GIST, meaning no KIT, not PDGFRA mutations, and I am going to use the term wild-type. We don't like it that much because now we know many other things, but give me permission to use it. They are SDH deficient. And 3/4 of them almost are secondary to mutation in this gene. But there is another 25-30% where there is no mutation, And what happens is that there is a hypermethylation, meaning a modification in the DNA that is not really a mutation, that changes the way the cell works. And this is phenomenal work that was spearheaded by Dr. Keith Killian, who is sitting in the audience and already waved to all of you, and we are really excited to hear more from him. After this, many other molecular features, very rare, single case, 2 cases, 3 cases have been discussed. NF1 has a significant amount of cases if you consider this in the context of a rare disease, but there are other situations that have been described. But the important thing is that by grouping cases and talking to colleagues, we have been able to have a better sense of what we call the natural history of the disease. In other words, how do you know that you're making an impact, that you're helping, if you don't know how the disease would behave otherwise? And that sounds very trivial, but it's not. So we have been able to learn a lot. And this has been able to allow us, in many situations, to give a message of hope. Because yes, it's a malignant tumor, but yes, it's very different from other tumors. Most patients survive despite disease progression. And a seminal finding of the clinic, despite the fact that we know that there is no magic pill or no magic drug that will take the tumor to remission yet, but we know, I think the most important finding is that a big, aggressive surgery, I took it all type of approach does not work, in the sense that it doesn't provide a better quality of life, it doesn't impact overall survival, and moreover, it can cause trouble, because many of you, and we see this every year in the clinic, come with a multiplicity of symptoms that are not related to the tumor, are related to the hemigastrectomy, to the gastrectomy, to the dumping syndrome, you name it. So to arrive to the fact that this is phenomenal work done by our colleagues Christopher Weldon at Boston Children's and Dr. Michael LaQuaglia at Memorial Sloan Kettering. Dr. LaQuaglia is sitting in the back, and you all heard his name.
Most of them have seen them at one point.
Yeah. So that is a critical finding of the clinic, to be able to change the standard of care in what it turns out to be surgical management. And I'm going to echo what has been said already. We recognize that we haven't been able to get this message across to the medical community as much as we would have hoped. Patients typically come knowing way better where we're at and where we're going than our medical colleagues, even in the big institutions around the country. So we are working very hard to address this among our colleagues, and we're going to try to see how to make an impact and trying to disseminate the message a little bit better. But one way or the other, what we can say after the clinic is that this approach to improve outcomes in rare diseases works. And that is something we did not know before the clinic was started, and I think it's a very nice takeaway. You saw this slide, so again, mostly young patients and almost exclusively gastric. Other thing that we learned from the clinic, and you saw a variation of this slide that is taken from a paper that Dr. Miettinen published, is that staining a slice of the tumor, what we call immunohistochemistry for SDHB, really works to sort out the cases that would be SDH deficient or wild type versus not. And that's a very important clinical tool that we are using almost routinely in gastrointestinal tumor cases, and that is a significant contribution. So, as the SDHB immunohistochemistry as a screening, the critical importance of molecular characterization. So, for every patient with gastrointestinal stromal tumors of any type, molecular characterization is no longer research or a luxury. It's part of clinical care. You need to know if you are KIT mutant. You need to know if you are SDH deficient. That's no longer research. It's clear, it's established, and we need to make sure that everybody knows. It's very well established for KIT mutant just, but we need to continue to push that envelope for SDH deficient. Most SDH mutations are germline. That means that are in any single cell of the patient's body and have the potentiality of pass through generations. So genetic counseling is an avoidable and a critical tool to implement in these cases. And we are very blessed to have a phenomenal genetic counselor, Margarita Raigara, in our clinic. We talked about location. We said that the response to imatinib is very poor. I am not going to say zero because that would be lying. But there are definitely responses to sunitinib and regorafenib, and we already talked about VEGF. We have implemented our other trials. Dr. von Meren ran a trial with a drug called incitinib. Many of you have spoken to her. This was led by Fox Chase Cancer Center. And we have led the vendatinib study at the NCI. Unfortunately, we didn't see the responses that we're hoping to see, which doesn't mean that we're not going to keep trying to find new answers. And taking advantage of the methylation pattern of these tumors that was published by Keith and colleagues, we have a de-methylating agent trial. This agent is called Wildtype that is currently open at the NCI, and we are definitely hoping to establish further collaborations with our colleagues in the UK to try to make the drug accessible there too. So again, this works, and improving outcome in rare diseases, and wild-type GIST is definitely one of them, is something that we are very passionate about, and we know that it definitely works. So the highlight. We hear the word collaboration many times, but I couldn't emphasize this enough. This is truly the spirit of the clinic, and it's not only restricted to 3 days a year. We continue to network through many different tools throughout the year. And that's another takeaway. When we don't know what to do, we reach out to our colleagues. And it's always a good sign when your oncologist decides to do that rather than the opposite. We talked about genetic testing. We talked about the lack of need of overly aggressive surgical intervention. Models. And we touched a little bit upon models. We don't have cell lines, and I am praying that Dr. Siklik's data is going to help us find a valid model to test drugs in. And we don't have, sometimes there are mouse models that recapitulate the disease, and we don't have this luxury here. And again, this slows down the progress of pharmacological improvement. But again, we know that sooner or later we are going to have it. And of course, the awareness. The awareness not only in the medical community, but only the awareness across the patient community. Because we know patients have told us very clear that the fact of knowing that there are other patients out there who are going exactly through the same is when they have come in maybe from situations where nobody knew what to do. And it's not a blame, it's just that it's rare. And in terms of the awareness, we're trying to give it a modern spin. So what else can we do to get the message across? So the latest thing that we did is to try to make a push to leverage social media. Because we live in 2018 and it's a tool that we can use. And used well can work, and we use poorly, well, you know the rest. So we recently hosted a Facebook Live with Dr. Margaret von Meren and Becky Owens, who is sitting here, and you know, and she did a phenomenal job in moderating this Facebook Live. And we have had a higher than expected amount of clicks and links and questions, not all of them through Facebook, but through repetition, and I think that that is an important way to reach out. So what are our future considerations? Well, we are continuing to think and redesign what the mission of the clinic is. We want to improve the outcomes and the quality of life of our patients. We want to empower them, both the patients and families, and we want to make sure that we are doing as much as we can to find a cure someday. We are considering, as you know, the organization of a consortium that is going, that we are very happy about. And just to pass it along, this model has worked so well, and many of you have been part of it, so this is a big thank you, that in the context of big cancer initiatives such as the Moonshot Initiative launched by Vice President Biden many years ago, we are starting to implement clinics in other rare situations based on this model. We have had many discussions with colleagues who are not specialized in GIST, who come and say, hey, how do you do this? Do you know how Lee set this up? Do you think we could set it up this way? what are the pros, what are the cons, and this is powerful. This is really powerful. And this really, from the NIH, makes us live up to our mission and makes us incredibly proud of being part of such a team. And again, the future clinical trials that we aim to do, we hope they can be based on real data, model-generated data. So we need to optimize the ways to get there, and we're working very hard to do that. So this is part of the team now. You can see we're very serious people. And I would like to thank all of you for the trust, the work, the hours, the anxiety that you share with us. None of this, and I say this every year in the clinic, there is no way we could share this kind of information with patients who come if we didn't have the information of patients who came before. So just because of the fact of walking in, you are helping the community. And you should keep that really, really, really close to your heart because it's absolutely true. And with that, thank you.